Welcome. Come with me. The doctors will see you now.
Welcome back to Fast Talks with Family Docs. I'm Dr. Phil Palmer.
And I'm Dr. Veer Vadala. We've been sitting with Dr. Whitney Crowe, faculty at the Great Plains Residency Program and a advocate of menopausal medicine. She's got a certification from the Menopause Society, and we had a fascinating conversation about all things menopause in the last episode. But now, Dr. Crowe, we would like to shift some gears and talk about, your vast experience in the amount of procedures you do in clinic, and then how you're training the future generation of residents into moving on and learning the procedures and doing them in their own careers. What are some key procedures you do in clinic, and what do you think is an easy enough procedure, or like a procedure you think all family medicine docs should be doing,
Yeah. So I do everything from skin procedures and joint injections to birth control, and not just birth control for females. I actually do vasectomies as well. I think all family doctors should be offering simple skin procedures.
Yeah.
We all know how long it takes to get in with a dermatologist.
Dermatologist,
Right? Yeah. Why make your patients wait the 6 months to a year that we're often seeing for their wait times when it's something you can easily perform in clinic?
Yeah.
And they're pretty fast too.
Yeah.
They don't take up a lot of time. Patients are usually really happy that they were able to stay with you and get the procedure done. Yeah. So that one is one that we should all be doing. Another one that I think is often missed by family doctors is vasectomies. The training might not always exist everywhere, but it is something that you can easily train in. It's an office procedure. You don't have to refer your patients anywhere. They get to come see you. You do the vasectomy. You send them home that day, and you see them in a few weeks to make sure it worked.
Yeah. Do you have a dedicated day to do the vasectomies?
So at the residency clinic, not really. It's all about my scheduling and when I'm available to do it.
Yeah.
But I think if I had a robust enough vasectomy clientele, then yes, it would be great to just be like, Wednesdays are vasectomy days.
Yeah.
We line them up and we do all the vasectomies.
Yeah. And a lot of times people want them on a Friday so they can go home, rest through the weekend, and go back to work on Monday.
Fridays are really an ideal day, right? They Saturday, Sunday off, and then they're good to go Monday.
Yeah.
Although a lot of times the guys don't grasp it's an office procedure. Because surely I need general anesthesia if you're going to be operating.
Yes.
Wait, I'm going to be awake for this?
Absolutely, yeah.
Yeah, it was. You're right. I didn't get that training in my residency program, but Dr. Rama at OU, while I was faculty at OU, he would have a dedicated day, and I went back and watched a few with him. Like, probably not for me. And then for skin procedures, you're doing like punch biopsies and simple removals of like lesions, and probably do a lot of cryo and all that, right?
Yes, yeah. I mean, the residents are doing cryo
all the time,
right? But yeah, punch biopsies, simple excisions, shave biopsies. All of that. We're doing it, and it's fast. So.
Yeah, awesome.
Now, picking up joint injections, did you get a strong exposure to that in your family medicine clinic during residency, or was that more something you picked up on ortho rotations or an elective? How did you acquire that skill?
So both. At my residency, we had a dedicated sports medicine rotation.
Okay.
And during that rotation, Friday mornings was sports medicine procedure clinic. And so you had 8 people on your schedule that were there for joint injections, and that's all you were doing. They'd already been seen by someone else. We had like an upstairs clinic, and then the bottom was our procedure clinic. Okay. So they'd already been seen upstairs by their, primary care physician, being sent down for a joint injection. So you just went in, you did all your joint injections, and that was it for the day.
That's got to be a fun morning.
Yeah, it was. And then the afternoon was actually other procedure clinics. So it was like IUDs and skin procedures and things like that. So
that sounds
if you were there, it was a great day.
I actually had that for a period of time. I was part-time with the residency when I went into practice, and part-time in a private sports medicine clinic. And there was an orthopedic surgeon that was really big on hyaluronic acid injections. And that was in the earlier days before the evidence really accumulated that maybe they don't do everything we hoped they would do. But at that point in time, the evidence seemed to suggest it was a very valuable intervention, and he didn't want to take clinic time to do knee injections because he had pre-op patients he wanted to see and post-op patients he wanted to see. So he asked me if I wanted to see them, and I'm like, I'd love to.
Yeah.
And so, I had a lot of those clinics where it was just a morning or an afternoon full of one injection after another.
Yeah.
That's awesome. So a question for both of you guys, since you both do a lot of joint injections. For us in outpatient primary practice, knees, shoulders, right? Do you guys do a lot of like carpal tunnel or any of those specific types of injections? I know like some of the hand orthodox do, metacarpal joint injections and stuff. What is the width of your joints that you actually inject?
Yeah, we are doing carpal tunnel injections. We are trying to be better about, point of care ultrasound and using that to help guide us as well. Carpal tunnels are a big one. Knees, shoulders. I have not had any SI joint injections since I've been here, but that is something I did in residency as well. But I think those are the big ones that I'm thinking about right now.
Greater trochanter of the hip, probably.
We do a lot of that. I have done carpal tunnel injections. I think, at least in my experience, I've seen a fair number that will get better just with immobilization and kind of conservative interventions. But if it persists, there's not a huge number of people that are excited about getting the needle put there. But if patients are willing, yes, I've done that in the clinic as well. I've done ankles before, plantar fascia a few times. I've done AC joints before. I've done an SI joint before. Those are both smaller joints that I think it is. And again, I should say when I did those, it was before the days of POCUS. And so those are such small joints that to feel like you truly got into the joint and deposited the steroid in the joint, doing those blindly, those are not injections I would do anymore. But if there's an ultrasound for the ability to feel like you had more confidence to actually enter that joint, that can certainly be done in the office as well. I've done not any elbow joints, but I've done lateral epicondyle injections and that kind of thing as well. So
and then there's another curious question. I don't know how many family docs are doing this. I definitely don't. But there's in occipital neuralgia, I saw like family docs doing suboccipital injections. Have you guys heard about this? And is that something being taught in training now?
I have heard about that. It's not something that I'm familiar with. It's not something we're teaching at our program. I can't speak about other programs, and I don't know if you.
No, I've heard about it, but I have never done it. So
and it'd be interesting. Gives him Botox for migraines, and that's fascinating stuff that's happening.
Yeah, but that using a needle is certainly a skill that's been one of my passions the whole time I've been involved in residency training, is to help residents understand that you should do this because you know the anatomy, and that's really all you need to do. And if you happen to have an ultrasound in your office, it makes it even easier and can give you even a higher comfort level. But even an ultrasound isn't necessary. You know the anatomy, you can do almost any, if not all, these injections without an ultrasound. And I think it's part of what family medicine is about. I mean, if I can take care of something, why would I send them to a consultant? Why would I give them an extra visit and an extra copay, more time off work, all that other kind of stuff? If I can offer that service there, and if it's made them better, that was the ultimate goal. And if it didn't make them better, now that specialist knows this conservative step has failed, and there's more evidence for them to do what they do as a subspecialist, as a surgeon, whatever the case may be.
Exactly.
No truer words have been said, sir. I wish everybody understood that logic. But Dr. Crowe, moving on, we talked about procedures. This has been great. You are a full spectrum family medicine doc with OB, right? And that is a valuable asset that not a lot of us family docs do anymore, right? What inspired you? I guess you both do that. Sorry, Dr. Palmer.
No,
you're amazing too.
But we're talking to her.
Yes. But what inspired you to keep up that film? And did you get a really great experience? And I mean, you're also doing a lot of women's health. What inspired you to keep going with that?
Yeah. So in medical school, when I was debating on what I wanted to do with my life, I went back and forth between family medicine, OB-GYN, pediatrics, and everyone kept telling me, oh, you're going to know if you want to do OB-GYN or peds, because when you deliver your first baby, you're either going to want to stay with the mom or you're going to want to follow the baby. That's what everyone kept telling me. And I never...
Don't get it.
I never had that desire. I was like, how's baby doing while I'm repairing my laceration, right? And I didn't really know that family medicine with obstetrics existed. I did my third year rotation at Great Plains, and I was following a third year. And he walked into a room, or he said, we're going to go see a 3-day-old baby that I delivered a few days ago. And I was like, wait, I can deliver the baby and see the baby? And so I actually went home that day, changed my application from OBGYN to family medicine, had to find all new letter writers and everything. But that's ultimately why I chose family medicine. And I think doing OB just goes along with the continuity of care that we are stressing to residents and medical students. Being pregnant is a normal part of a woman's life. It's not a disease process. It's normal. People get pregnant and it happens. And we should treat it as this normal thing and just part of their life. And if we really focus on continuity of care, then providing obstetrical care is part of that.
And you go beyond that to a certain extent because even a lot of family docs who do obstetrics don't necessarily do C-sections and tubal ligations and things like that. What piqued your interest to add that to your repertoire?
Well, I remember I was delivering a baby in medical school, and it was with the family medicine residency. Unfortunately, she did not progress well and needed to go back for a C-section. And I was so sad that we sat there and we pushed with that mom for 2.5 hours, and we did not get to follow through with the delivery. And I think ultimately I was like, no, if I'm working so hard to help this woman, not working hard, they're the ones working hard, right? But if I'm spending time with this woman and watching her through her pregnancy, then I want to be the one who gets to stand with her to the end.
Yeah.
And so being able to provide the C-section was something I knew I wanted to do from the beginning.
Excellent.
Yeah.
Excellent.
And that's a really unique asset, I think, right? Because not a lot of people can say, especially living in Oklahoma City, be able to do that.
Yeah.
And props to you guys for doing both. So a lot of you're obviously teaching the future generation of family medicine docs. What advice would you give like early career family medicine docs or people just graduating residency or even your trainees, I guess, now to keep up this full scope of practice? Like, would you say to like, hey, keep up your skills while they're still fresh, or have them pick and see what they're passionate about, I guess?
Yeah. I think my biggest advice is in the beginning, when you are looking for what residency program you want to go to, find a program that's going to train you in as much as you can possibly be trained in, right? It's really easy to step back later in life. We can always cut back and find what our true passion is later in life, but it's really hard to pick up new skills as we go in practice. Yeah. So find somewhere that's going to train you in everything that you can be trained in, and try to keep as many of those skills as you can in the beginning, because life changes, your goals in life change, your priorities change, and that way you have more flexibility, right? That's the great thing about family medicine is we have so much flexibility to change not really your career, right? You're going to still be a family medicine doctor, but change your practice over time as your priorities change.
Yeah, if you learn all you can while you can in residency, then it's easy to pick and choose in practice.
Yeah.
But if you kind of pick and choose in residency and you get into practice, as you said, then it's harder to go, I wish I had that skill.
Yeah.
How can I gain it?
And that's, that's the big things, right? There's still things you can pick up, even if you've been practicing for 10 years. Go back to joint injections. You still know the anatomy, like you said. Like that's something that you can easily pick back up doing. So if you are out in practice and you want to add more procedures, it's not impossible.
Yeah. Never too late to learn something new.
That's right.
Yeah. But okay, so I guess in the current atmosphere, we see a lot of family medicine training somewhat even moving a little away from obstetrics. You guys, would you agree with that maybe?
People are trying to push it.
People are trying to push it. Yeah. So what gives you hope? Like what do we need to do to advocate to include that additional training so the residents can learn as much as they can while they're in training, and then they can make that decision afterwards.
Yeah, I do think the culture is pushing family doctors away from full scope, and especially with obstetrics. But unfortunately, the reality is that the U.S. has the #1 maternal mortality for any developed country, right? And part of that is in part due to all the maternal deserts that exist. Oklahoma has a lot of maternal deserts. Right. We have rural areas where people are traveling hours for OB care. Yeah. And this is the perfect spot for a family medicine doctor to practice obstetrics and to provide that care. So I think we just have to continue pushing that. And letting people know that there is a spot for us in obstetrics. Now you have to know when you need to ask for help, and that's totally fine. Everyone needs to know when they need to ask for help. Right. But as teachers, it's also our job to continue to encourage medical students and residents to get that training, to know that they will be needed in certain parts, and to try to really just provide that care that is lacking.
Yeah. And family medicine has an OB fellowship they can do.
They do,
right?
yeah.
And so that's some additional training that if people don't feel comfortable that they can pursue.
Absolutely.
Right. And I think the American Academy of Family Physicians is a great resource to help push back against that move to shove family docs just into the clinic and not in the hospital and not be doing all these different procedures, including OB. I think one of the valuable things, and I know there are programs in the northeastern part of the U.S. And probably elsewhere, but I know certainly there where the family medicine residencies do not have family docs that do OB. And so the family docs learn their OB by following OB docs around and watching OB docs do their deliveries. And a lot of times it's really maybe even just an observational experience and not even really a hands-on learning the skill type of experience. I'm not familiar with the DO programs in the state. I would assume they're the same as the allopathic programs. But to my knowledge, all 5 of the allopathic programs in Oklahoma have family docs doing the obstetrical training of those family medicine residents. And I think that's one of the key pieces of helping medical students rotating in that experience and residents while they're going through that training to continue to see their mentors doing that full scope, continuing to deliver that aspect of care that helps them recognize this can be done.
Yeah. And I think I know some of our OB colleagues, like I did a lot of OB in residency in Kansas, and my mentor, Dr. Melissa Haig, was an OB-GYN, and she was a huge proponent for family medicine docs doing OB, and I think that camaraderie still needs to exist. You know?
No, absolutely.
And she's very disappointed in me right now because I don't do it anymore. But
yeah,
okay.
I agree with what you said, Dr. Palmer, but I also think we have a lot to learn from our OB-GYN colleagues as well. And one of my mentors is Hector Chapa, and he's a well-known OBGYN that is still at my residency program and providing great training. And it was amazing to get to see how a family medicine doctor does OB care, right? Obviously, we all have these guidelines and things that we're following. We have a little bit of a special skill that we get to bring to the table.
Yeah.
We treat all these medical conditions that these women come in having.
True. Yeah.
And so we can, like I said earlier, I will harp on it, that continuity of care that we can provide to them is so important and so different.
Yeah.
So.
It comes a very, I have like a vivid memory where I was delivering a baby with one of my OB doc mentors or, preceptors, and then the baby wasn't doing so well. She's like, you need to go over there and check on the baby. I'm like, yes, I can do this at RP, you know? And so again, sitting here talking to you guys, it's inspiring to see the width that family medicine has to offer.
Absolutely.
I'm glad we're here doing this podcast.
Absolutely. Dr. Crowe, thank you for joining us tonight. I really enjoyed getting to know more about you and your practice.
Yeah, thank you so much for having me. I really enjoyed it.
Thank you, Dr. Crowe.
And followers, we will see you next time on Fast Talks with Family Docs.
Thank you for joining us today. The doctors would like to see you back for another check-in. Please choose to follow our podcast and you will automatically be notified when it's time for your next appointment.